Hi, everybody. Welcome to our USMLE Prep Question Live Series. Unfortunately, this is pre-recorded and we couldn't go live today because we were having a little bit of technical issues with the lag time and things like that. So without further ado, we'll present our wonderful Dr. Roland Zhang. Hi, Roland. How are you today?
Doing well. Thank you so much. Thank you for steering away co-host. So, but just you and I today, like always, right?
Just
so,
the two teams. Yep, we got this.
We got this. Murphy's Law. Actually, have you heard of coleslaw?
Whose law?
Coleslaw, yeah.
No, what's that one?
Cabbage, mayonnaise, carrots, sugar. Thank you, everyone, for joining us today. Once again, we're recorded, but it should be live. Today, we're talking about the RAAS system. Once again, the lovely Miss Megan, and then me.
And then me.
So today's agenda will be a little bit different because so it'll be all about me and Megan today. So we're going to look at the question of the we're going to review the RAAS system, ACE inhibitors, and how they affect time. And then we're going to answer the question together. Unfortunately, due to technical difficulty, it won't be as interactive as I hoped, but hopefully, this video we can kind of watch again and again, learn it together. So after we answer the question together, we'll review all the wrong, right, making sure that you know why they're incorrect. And then finally, we'll talk about basic strategy, how to tackle questions with the increase, decrease, the up and down arrow. Very tricky and very confusing. At the very end, we have the Q&A. So here's the question, and let's tackle it like you're doing the MBME or first things first, we read the question. So which of the following findings are with the medication given to his patient to prevent progression of diabetic? So we're talking about medication, pharmacology. We're talking about diabetic nephropathy. So what kind of medication is given to prevent that? So what do we have? 54-year-old man coming to a clinic for follow-up. The patient has no complaints, feeling ill. Past medical history include diabetes mellitus type 2 for the past 20 years, hypertension for the past 22 years, and erectile dysfunction for the last. Current medications include captopril, sildenafil, as 10-pack per day smoking history and drinks 2 beers daily. Man, I'm sure his primary care doctor loves him, right? No past surgical history. History includes pancreatic cancer, and his father, type 2 diabetes, and hypertension, his mother. And once again, we're looking at the medication given to his patient, progression of diabetic nephropathy. So the question writer was kind enough to give 2 medications off the bat, captopril and sildenafil. And we'll talk about both, right? Okay. In time, which medication actually helps prevent diabetic nephropathy? But the choices. Skip this for now, the increase, decreased, right? Just look at renin, angiotensin 2, and then angiotensin 1, potassium. So off the bat, reading the question, going to take you, 15, 20 seconds. I'll take it back, maybe a little bit more time, right? The general framework of what we're trying to figure out, what medication and how does it work to diabetic nephropathy. Okay, so let's do a quick review of the diabetic nephropathy and how to prevent it with the medication. So in this case, let's give it away. We're talking about captopril. And if you remember your pharmacology 101, captopril is a inhibitor, and we'll go through how they work. Okay. Let's take a look at this picture. So here's a nephron under physiological conditions. So in a healthy nephron, nothing affecting it. So we have the efferent arteriole and the efferent arteriole. So blood is going through here from the screen, going to the glomerulus, doing all the fun little loops here, then traveling back out through here. At the same time, the glomerulus has fenestration, so tiny little holes for fluid, for some ooze their way out. So as they ooze out, they get reabsorbed through the Bowman's. Right? So stuff goes through here, travels through here, goes out, and then stuff gets filtered or through here. So let's talk about a little bit of math, right? So there are a couple of factors coming into play, and that's the capillary pressure and the oncotic pressure. So capillary pressure is the amount of pressure actually forcing the fluid out. So if we think of this area right here, think of like a plastic bag. So going to a plastic bag and a pipe coming out of the plastic bag. So how are ways that we can make the plastic bag excrete more fluid or make it more leaky? What we can do is that we can increase the amount of fluid going into the bag. So if the afferent arteriole, if we make more liquid going into the bag, then theoretically the pressure up, right? So the pressure go up, you have more stuff going out here. Same time, we have the oncotic pressure. So oncotic pressure, remember in basic high school biology, a thing of blue water, a thing of clear water, and then a semi-permeable eventually kind of goes its way through. Well, if you have a very heavy solute, it actually pulls the, you think about, if you put a goldfish, no, don't do this, you put a goldfish in a tank of very salty seawater, it'll die, right? All the fluid's being pulled out of the goldfish into the saltwater tank. That's actually a really bad analogy, but kind of like, right? It's just pulling fluid. So once again, we're pushing fluid through the capillary pressure, and then we're pulling fluid from the oncotic pressure. So we have two areas, the glomerulus and the Bowman's space. So the glomerulus has two factors, pushing out fluid, and one is pulling in fluid. So if you look at here, this is pushing out. This is actually pulling in fluid. So the GC is the glomerular capillary, is pulling in fluid. At the same time, the Bowman space is doing, it has pressure going back, so pushing from here into the glomerulus. It's actually out too, so oncotic pressure of the Bowman space as well. So right here, the Bowman space. And if you look at this formula, I'm not a huge fan. I actually like it this way. So the pressure of the glomerular capillary plus the oncotic pressure of the Bowman space. So this plus minus this plus that, so algebra, right? The formula works, but whatever helps you remember. In my case, I'm thinking all the factors pushing or pulling out fluid, subtracted all the factors pulling in fluid from the Bowman space. Ms. Megan, you with me? No,
yeah, no, I'm still with you.
Unfortunately, you're my foil.
I love the Freddie Mercury in the corner.
Yep, perfect, thank you. So once again, let's take a look at the patient. So on the left, we have prostaglandins, and they dilate the afferent arteriole. So if you dilate this area, you have more fluid going into here. So more, you have an increase of pressure, you're actually forcing more stuff out. Cool. Okay. Now here, let's take a look at this section here. This is actually pretty important. Angiotensin 2, efferent arterioles. So once again, we have the pipe going in to the bag and pipe going out. Squeeze the pipe going out. You have a buildup of pressure going back into the glomerulus, right, causing increased pressure here. So here, we're dilating, more pressure going in, restricting, preventing the material to be leaving. So increase it, right? Okay, great.
Yeah.
But this is really bad. No, this is bad, causing an increased amount. You have a lot of, could cause damage to the Bowman space over a long period of time. So what happens? What can we do to treat that? Well, ACE inhibitors, talk about how it works in the next slide, but ACE inhibitors actually cause vasodilation. And here, we're causing constriction, causing increase of pressure here. Well, if we cause it to vasodilation, you're causing more pressure to go out here, but pressure to actually exit through the Bowman capsule. So we look at this big compared to a much smaller arrow as well. Right?
Okay.
One more thing to add to is that NSAIDs, so like aspirin, they actually cause vasoconstriction of the efferent arteriole. So if we think of a patient with renal damage, acute renal failure, or chronic renal damage, you want to avoid these kind of medication because limiting the amount of fluid going into the Bowman capsule. I was half joking with Miss Megan that here's the wonderful Freddie Mercury. I don't know why, but every time I see this slide or this formula, I hear the song, just elevator music at the back of my head. So too many years of stuff, but hopefully this kind of gives you a quick glimpse back at how does nephron work, the net filtration pressure work. The math isn't as important as more as the overall does it actually work, like what's going in, what's going out, what's dilating, what's breathing. Miss Megan, make sense so far?
Yeah, I think it's making some sense.
Okay, perfect. So when you go into medical school and join me as a medical doctor, be like, oh, second nature.
Be like, oh yes, Freddie Mercury. I remember this.
I know that guy. So is the RAAS pathway, and I know it's a little bit intimidating for trying to review this at the very first time, or even those of you who've seen it 4 or 5 times together. I pulled this picture from Emboss, the RAAS system. I actually really, really love this figure. I think it breaks down a lot of material and semi-easy to understand. Let's go through it together. Right?
Okay.
So, the body, the secret of life is homeostasis. Right? Oh gosh, what was that one book? Here, we'll skip that part. Secret life, like homeostasis, you want to return to normal. So if you have a patient who is hypovolemic, hyponatremic, right? So you have low blood pressure. Your body has many different ways to kind of realize that. So it can have the receptors, the chemoreceptors, the baroreceptors in the carotid area, and they're all trying to increase the blood pressure. So in the kidney, the apparatus, the macula densa, and what they all do is that they actually increase of renin. What does renin do? So the liver actually creates angiotensinogen, and the fact that it ends in ogen means that it's a zyme, inactive precursor to an enzyme. So an inactive enzyme to precursor. So it's traveling through the blood, but it's inactive. However, when the patient, when hypotensive, hyponatremic, you actually secrete renin, which activates angiotensinogen, cleaves off the factor, and makes it into angiotensin 1. At the same time, your pulmonary endothelium actually secretes angiotensin enzyme, which converts angiotensin 1 into angiotensin 2. The lungs over here made this, convert this to that.
Okay.
Angiotensin 2 is incredible, works in many different areas, does a lot of things. So let's talk about the central effect, affects the brain. So angiotensin 2 actually increases your appetite, increases your thirst, right? So once again, you're hypotensive, hyponatremic, so drink more water. I'm feeling thirsty, you drink more water. It also does ADH release as well. And for those of you who remember what ADH does, makes the collecting duct leaky, so you have more fluid going back into the body as well instead of urinated out. So that's one way that angiotensin works on the central to increase extracellular fluid volume, to increase blood pressure. Second one is through angiotensin 2 receptors. It causes arteriolar. So remember how we have the incoming pipe, the Bowman's capsule, and then the exit pipe? Mm-hmm. If you constrict the pipes and you still have the heart beating towards it, right, all the blood pressure going towards it naturally increases blood pressure as well. So now we have increased fluid, increased constriction, causing increased pressure as well. The third thing is proximal tubule. We actually have increased sodium reabsorption, and water follows sodium. All three, right? They're all working together to increase extracellular fluid volume, all increase the blood pressure. But there's one more key fact, right? Angiotensin 2 actually increases the release of mineralocorticoids in the specifically aldosterone. So aldosterone causes sodium retention, it causes water retention. However, one key fact is that two active transporters in opposite directions. So the more sodium you absorb, the more potassium you kick out. So think of the antiporter, one's going going up. So if you have a lot of aldosterone, you have low serum potassium. So one famous, actually, Miss Megan, do you know the famous US president who had a severe lack of aldosterone?
Of what?
A severe lack. So do you know which president had asthma disease?
Oh,
If this is a live seminar, I was throwing a trip all of them, but JFK Jr. had asthma disease.
okay.
Yeah. So
Oh, I think I did know that. Yeah, yeah.
he has a really interesting looking tan, but asthma disease, they actually have low aldosterone. So if you have high aldosterone, you have low potassium. So Miss Megan, low aldosterone, if you have low, we have high or low potassium. So low, we have high or low potassium if they go in opposite directions.
You go high.
Cool, yeah. So the reason why, it seems like very simple, but when you're doing a question, it's really easy to get it a little bit confused. So Megan was kind enough to kind of demonstrate that. The question, we're going to look at that again, right? Because when you have the NBME or step one, it's really easy to get confused about that. We'll go over a strategy for that as well.
Okay,
So
perfect.
cool. So now we have low serum potassium. We have high extracellular fluid volume. Pressure is going up. So this red arrow has negative feedback, shutting off renin, everything kind of shifts away. So once again, I really love, there's a couple of fantastic pathologies, fantastic pathophysiology, even that goes back to this. And we'll talk about that towards the end of today's lecture. Okay.
Great.
So let's go back to the question. So we know that taking captopril. Actually, a little bit of trivia. Miss Megan, sildenafil, have you heard of it? It's happy blue pill. Happy blue
yes.
pill. Yep.
Yep.
Yep. So sildenafil is the trademark name is by, actually a little bit of trivia. Pfizer created Viagra. I think it's a UK medication. I'm sorry, synthesized in the UK originally. GMP. So the way it works is that it prevents the breakdown of cyclic GMP. GMP works with nitric oxide to cause vasodilation in cavernosum, causing happy fun time. So sildenafil is what we'll be talking about today. Is captopril, a ACE inhibitor. So to reword this question, and something I kind of teach my students as well, take the question in your own words. So at the end of the day, what you're trying to do. So the question in my, which medication, in this case captopril, how does it work? So how's captopril all this, right? So once again, let's skip this for now. I want you to take these four and think of aldosterone. So Miss Megan mentioned aldosterone, how opposite potassium. Yes. Pretend there's aldosterone right here between these two. And one more thing, the test writer actually has angiotensin 1 and 2. Right? So a very devious way of making it a little bit more tricky. Let's take a look at the question together. So this is the exact same slide as one, but they actually have the medications here. Right?
Oh, okay.
So 1, 2, 3, 4 medications. So let's go through the answer choices one by one. But instead of doing that, let's step back. Instead of looking at these, let's go through it together. So we have an ACE inhibitor shuts it off here. So we stop it here, right? Stop it here, angiotensin will be up or down, it'll just be going down, right? Angiotensin will be going down. If angiotensin goes down, everything here, well, so angiotensin 2 goes down. Aldosterone, like Megan said, if aldosterone goes down, potassium goes up, right? Angiotensin has to go down, potassium has to go up. Cool. Okay. But at the same time, if we show here, you don't have the increase of blood pressure. Well, the body doesn't know it off. So the body will naturally try to release more renin, right? Because they don't know that you should. So the renin will actually be going up because they don't have that negative feedback. So renin will be going up, angiotensin will be going up as well. All of these, renin goes up, angiotensin goes up, angiotensin 2 goes down, potassium goes up. So option E for echo, correct answer, option E. Let's go through all the other answer choices and kind of think what kind of possibilities could create that likely scenario.
Okay.
So how about the first? So the first one, we have increased renin, increased angiotensin 1, angiotensin 2, and decreased potassium. So basically, just like this, exactly. So what could cause that? Well, hypotension if the patient was hydrated over a long period of time, hypernatremic, they're not having a very low sodium diet as well, or if the patient had like a renin secreting tumor. So the absence of renin, this whole thing will run like a vicious cycle, right? So option A for if you have any of these symptoms, any of these causes, or if you have renin, you'll have option A running. Cool. Let's look at for beta. You have a decrease of renin, decrease angiotensin 1, of angiotensin 2. So the first three are complete polar opposites of option A, right? So what can happen here? Well, like I mentioned before, well, if you have too much pressure, the whole negative feedback. So I could argue that maybe a patient who is hypertensive will not have this kind of scenario.
Yeah.
Interesting factor I was trying to figure out earlier was that the test writer actually has potassium. But like Ms. Megan mentioned earlier, if you have a drum, you have low potassium. So theoretically, if you have low angiotensin 2, you have potassium. Why is the potassium decreased? I was trying to look this up at times. I apologize, but I put a little star right here because I'm not sure if that was the way to say this is incorrect. It could be one way to say that. Take a look at option C for Charlie. In this case, we have an increase of renin. Okay, fine. Decrease of angiotensin 1, decrease of angiotensin 2, decrease of potassium. So in this case, we're chopping it right here. So aliskiren is a renin, I believe, analog, right? So if we give this medication here, everything from angiotensin 1 decreases. So everything down here goes away. So kind of like ACE inhibitor, but you're moving back a step, cutting it off here. Okay. But at the same time, why is potassium decreased? Right? For the exact same reason earlier, if we're having a decrease of aldosterone, should potassium go up? Should be a little bit elevated, but he or she has decreased here as well. So option C is incorrect.
Okay.
Cool. Option D for delta, we have decreased renin, increased angiotensin 1, decreased angiotensin 2, increased potassium. So the fact that you have no renin here or decreased renin, increased angiotensin 1, decreased angiotensin 2, just completely out of the picture. It doesn't work that way. So option D should be the first one, doesn't work. Okay. Cool. So that's the slide in a nutshell.
Great.
So, okay, what now, right? How do we actually tackle this from now? So what I recommend is that be able to sketch out the RAAS system. So this diagram right here, be able to sketch it out in another 10 seconds. It should take you around 10 seconds to sketch it out, and then use that opportunity to kind of teach someone, talk it out, teach someone, kind of exactly what I did with Ms. Megan. Be more nicer to Ms. Megan, but be able to kind of explain to each other if you have a decrease of blood pressure, walk your way through. Right? Okay. 2, don't look at the answer choices. So here we have renin, we have angiotensin 1, angiotensin 2, aldosterone, and potassium. Don't look at the answer choices. Just kind of draw it out, like up and down arrows. So if you have increased renin, increased angiotensin 1, increased angiotensin 2, increased aldosterone, decreased potassium. So fill out the answer choices. It'll save you a lot of headache and heartache when you, so you don't have to think about this question again when you're doing the next question, the next block. Just write it out, figure it out, and move on. And I think, in my humble opinion, it's okay as you're studying, if you forget this or you don't remember. There's so much material out there that's completely okay. to kind of review this, because each and every time you look at this, you get a little bit faster, you get a little bit more comfortable with this material. So the last part before I let you go, I do recommend to take a look at this again. And for those of you who want to do above and beyond, well, actually, no, you need to know this. I take it back. You need to know this. So I am not that savvy with social media, but I think hashtags are something that ties things together. Megan, you're the expert, not I. But
yes, they do.
okay, so I took a liberty of putting some hashtags, which in my opinion, go really well with the RAAS system. So for example, congestive heart failure, are we talking about systolic versus diastolic heart failure or both? What kind of medications can you use to manage heart failure? I mean, beta blockers, diuretics. What do you want to do? Which medication work better for one case over the other, right?
Mm-hmm.
Second one, diabetes insipidus versus SIADH. How does the antidiuretic hormone play into both? How about DI? Are we talking about central? Are we talking about nephrogenic? How about kidney physio 101? Let's go over the proximal kidney tubule, the descending loop, the ascending loop, DCT, convoluted tubule. So these are all things that work well together to understand the overall bigger picture. Diuretics, the bane of many a medical student, right? How's pharmacology work to release fluid? So diuretics is very high yield. I really highly recommend to kind of take a look at them as well. But take a look at it, trying to understand the overall pathophysiology, how it's all tied into it as one giant unit. In hypertension in general, how do we manage high blood pressure? So at that note, thank you so much. That is the RAAS system in a nutshell. I apologize for technical difficulties. If there's a live audience, we'll be doing a lot more fun trivia, but Megan has been kind enough to humor me.
Oh, yes. I mean, I'm not as exciting as some of our lovely little volunteers that comment into our questions, which we love seeing. We love seeing all of your comments as you break it down with us. Tell us what you think is happening in the question and kind of play along. We like to see it. But thank you so much, Dr. Zine, for joining us today. We appreciate you, as always, for taking your time out of your day. And we love the, the joke you put up on the screen.
Thank you so much. No, it was my honor, and I really enjoy teaching. So I think one reason why I enjoy doing this is that by teaching others, it makes me kind of review it again on my own. So never stop learning, never stop teaching. Once again, sorry that you couldn't join us, and we look forward to having all of you next week or the week following, right? The week following.
Yes. So next week we will be posting a new question on social media on all of our channels, and then we will follow it up with the following Thursday when we'll go live, hopefully without technical difficulties, with our new kind of question and answer. So we look forward to seeing you then. Have a great day, everyone.
Thank you.
Bye.